Welcome, doctor trainees. I'm Dr. Untara Shaikh, and today we will be going over the questions and answer based on the lecture of management of pneumonia. So let's start. Our first question is, briefly describe signs and symptoms along with management of pneumonia in children. So pneumonia can occur at any age, okay? And it's very common in young children. Pneumonia accounts for about 13% of infectious illnesses in infants. They are younger than 2 years. The newborns are the one how they will present. They will present with poor feeding, irritability, tachypnea, retractions, grunting, and hypoxemia. Whereas infants are going to present with cough along with tachypnea, retractions, hypoxemia, and these may be accompanied by congestion, fever, irritability, and decreased feeding. Now a little bit older children, like younger children or children in adolescence, they will present with cough along with tachypnea, retractions, hypoxia, congestion, fever, irritability, and they will also have constitutional symptoms such as headache, pleuritic chest pain, and non-specific abdominal pain. Briefly describe signs and symptoms along with management of pneumonia in children. So in outpatient setting, combination therapy of ampicillin and either gentamicin and ceftriaxone is typically used in the initial treatment of newborns and young infants. High dose amoxicillin, second or third generation cephalosporins and macrolides such as azithromycin. These are alternatives. Then if a patient is in hospital, so ampicillin if in high resistance areas, then third generation cephalosporin. Older children, we can give them macrolides to cover atypical infections also. Number 2, what will be the pediatric dose and duration of antibiotic in OPD? It's the same question from previous. In the lecture, treatment of CAP in hospitalized patients and in patients with CURB 65 score more than 3 is different. What's the significance? So the one that we do CAP is because it's going to identify high-risk patients, okay? And decreasing the relative weight of age and blood pressure, eliminating your use of imaging and comorbid illnesses in calculation. So that's why we are going to use the curve, and based on that, then we treat the patient. So it's a very good tool to use. Number 4, how is COVID pneumonia different from other viral pneumonia? So symptoms of pneumonia of the COVID may be similar with other viral pneumonia, because it's very difficult to say that, okay, it's viral or it's COVID, okay? So now, but they have figured out what is going to be different in COVID. So COVID pneumonia patients were more likely to have pneumonia that affects both lungs as opposed to just one. Lungs that have characteristics ground glass appearance by CT scan. Abnormalities in some lab tests like liver function tests, that will be different also. How does Legionella cause hyponatremia in patients with pneumonia? So Legionnaire's disease, okay, they have syndrome of inappropriate antidiuretic hormone. So syndrome of inappropriate antidiuretic hormone, what happens in that, they have too much of antidiuretic hormone. So when they have too much, what they are going to do, they are going to reabsorb a lot of water in collecting tubules. So that's why we will see decrease in sodium, okay? In Legionella disease, Legionella is the one, Legionella, they will have hyponatremia because of syndrome of inappropriate antidiuretic hormone. Number 6, which one should be preferred for diagnosis of pneumonia, blood or sputum? Okay, so there is the thing. Blood cultures should be obtained in all hospitalized patients with community acquired pneumonia. Blood cultures are not required in outpatient management. Gram stain and cultures, an initial sputum, gram stain and culture, or an invasive respiratory samples are as appropriate, should be obtained in all hospitalized patients with community acquired pneumonia. Number 7, what is the importance of nasal swab in pneumonia? Does it help to isolate the organism? Yes, it does help. Number 8, What are the findings of X-ray in the case of lobular interstitial pneumonia? So let's see. I got these for you guys. So we see this one is over here. We have lobar pneumonia. Okay, lobar means the one lobe is going to be consolidation we are going to see. So ill-defined areas of high density, like right upper lobe is the one that is going to show us in proper clinical settings, like the lobar or segmental pneumonia is there. Okay. So this is our acute lobar pneumonia that is caused by Streptococcus pneumoniae. Now this is our interstitial pneumonia. An acute reticular pattern is there, okay, and other causes, it can be viral, it can be pneumocystis jirovecii, it can be mycoplasma pneumonia. They present with non-productive cough and some fever, okay. Number 9, how can we treat Pseudomonas and MRSA as outpatients? So that was given in your lecture basically. So I just, let's recap one more time. Outpatients with no comorbidities and no risk factors for drug-resistant strep pneumonia include the following: amoxicillin or azithromycin or deoxycycline, okay. How can we treat MRSA and these? So now patients with comorbidities, combination therapy is given. Amoxicillin, Colbinate like Augmentin or Cefepodazim or Ceforexim. Okay. Plus we need to give them azithromycin, or we can give them clarithromycin, or we can give them deoxycycline if a patient have contraindications, or we can give them respiratory quinolones. Okay. So these are the combinations in that we can give them. What is the dose and duration of oseltamivir and zanamivir? And are they in injectable form? No, they are in oral and powder form. And what are the names in Pakistan? So oseltamivir is Bemiflu, Tamiflu, and then zanamivir is Relaxa. That's Reddish, your inhaler, 5 milligram. Please give us few brand names of antitussive, steroid safe in pregnancy. Vicks and dextromethorphan, that's cough cold. And I would like to thank our following e-doctor volunteers: Dr. Sabuhi, Dr. Hira, Dr. Asiya, Ashfa, Iram, and Misha. Good luck to everybody and happy studying.